Hello, everybody. My name is Benjamin Day.
And I'm Jillian Mason.
And this is Medicare for All, the podcast for everybody who needs health care. Now, we're going to start this one off. I'm going to throw some terms at you here, Jillian and everyone listening. Open enrollment, deductible, coinsurance, HMO, indemnity plan. Do you feel your blood pressure rising?
Oh, my God.
If you've listened this far, you've probably already got a migraine. Understanding even just like the language of the health insurance industry, never mind selecting a health insurance plan, can be confusing, frustrating, disheartening. But never fear. We are here to give you a crash course on everything you need to know about insurance plans. No need to scroll through Healthcare.gov's health insurance glossary. I really highly recommend you don't do this. You may risk throwing yourself out a window, but we are going to break it all down for you. We have duct tapes ourselves to our seats to prevent ourselves from throwing ourselves out of any windows or other high places. And yeah, this episode is going to be like a little different from what we usually do, and hopefully it can serve as kind of a resource for you to bookmark the next time you need it. And I know we are in open enrollment for a lot of people right now, so you might need it immediately.
Yeah, absolutely. This is like, we're trying to provide a little service here. Usually we just make you listen to us rant. So this is our gift to you. Just
only one time. That's it.
Oh, wait, but I did want to offer a brief disclaimer, which is that we want to give you some tools here to understand what you're choosing when you pick a healthcare plan, but no one but you actually knows what's best for your health. So for better or worse, we're not actually going to give you any advice here about what healthcare plan to pick or say that one is better than the other. In part, that is also because all health insurance kind of sucks, right?
Yep.
So you're probably going to get screwed no matter what you pick. But so basically what we're going to do is we're going to try to decode all the mystifying language that the insurance companies use to disguise the particular ways in which they're going to screw you. So at least you'll be able to anticipate how they're going to screw you in the future. Does that make sense? Yeah.
Oh, it's my most fun activity, anticipating screwage and the different variations on it. So I thought we would start off with the most basic, which is just the name of the insurance plan you might be looking at buying. The name usually tells you what type of an insurance plan it is. So this is, whether you get your insurance offered by your employer, and you have to kind of choose from multiple options that they're offering you. Or if you're buying insurance plan on your own in an exchange or on Healthcare.gov. And then also some folks who are on Medicare, if you're looking at one of the privatized Medicare Advantage plans, you're going to see the same thing, kind of choosing among these private plans. And you're going to notice that they have just totally incomprehensible names and acronyms. So we're going to try and break the names down for you a little bit. So generally, the first part of the insurance plan's name will be the name of the insurer itself, like Blue Cross or United Health. Then you might get a word that says who is paying for the insurance plan. So if it says group, for example, that means it's an employer plan. If it says Advantage, that means it's a privatized Medicare plan. And then finally, there will be an acronym that only 0.005% of people in America understand. And those people are generally the ones making money from the plans. So these acronyms will be something like HMO or HSA or PPO or EPO, or my personal favorite, GTFO. That's the get the fuck out of here plan. That can't be a real plan. Just to give you a couple of examples.
Yeah, because this is once you have a certain number of acronyms in a sentence, it just gets very abstract,
Yeah, it is really overwhelming to look at these and to make any sense of them whatsoever. And I'm going to give you an example of that. So my wife just this month had to choose a plan, one of 3 plans offered by employer. And obviously I work in healthcare. So she's like, explain this to me. None of this stuff makes sense. One of the plans was called Tufts PPO and Cigna. That's confusing because there's 2 insurance companies in that name. The second option was called Tufts EPO Premium. The third one was Tufts EPO Value Deductible.
All of them sound great based on those names.
I was going to add a little proviso. Obviously, the first one is the name of the insurance company. the EPO, PPO thing, that tells you what type of plan it is. We'll talk about that. But when you hear words like premium and value, those don't mean anything.
Mm.
That's just fucking marketing bullshit. So ignore anything
Oh.
that sounds nice because it's not actually useful.
I just want to point out here, like, for those of you who are like, oh shit, I'll never understand this EPO, PPO, go fuck yourself. Right? If you're panicking right now, you should know that Ben's wife actually works at a university as a tenured professor. She's a very, very smart woman, much smarter than either Ben or myself, right? And even she was having difficulty understanding these plans. So it's just a question of understanding the stupid bullshit lingo, right? It's not because you're stupid that you can't understand this. This is lingo that's deliberately created to confuse you. Just wanted to throw it in there.
Exactly.
So, all right.
Exactly.
So we have all these different kinds of plans to choose from, right?
Right.
And they all start with Tufts.
Right. So Tufts, that's obviously the insurance plan. If you don't like Tufts, you're screwed because that's the only one you can get for this one employer. But it's the acronym soup in the middle that we want to break down a little bit and let you make sense of. Okay, so we're going to go through these one by one, the different kind of types of plans that might appear as an option. And I'm going to talk, I get the privilege of talking about indemnity plans. And we're only really doing this for historical purposes and amusement because no one is going to offer you an indemnity plan.
I love that, like, when we were planning this episode, Ben was like, I really want to talk about indemnity plans. And I was like, oh, is that important? And he was like, no, I want to talk about it because it's irrelevant.
Yes. All right. Here's why I have to talk about indemnity plans. And there is today 1% of workers have indemnity plans. So there is a chance. There is a chance, maybe if you're the one, literally the 1%.
The other 1%.
Yes, the worker 1%. All right. But here's the crazy thing, right? Basically, everyone had indemnity plans before the 1980s, like 100% of workers. So back in 1978, which is very close to when I was born in 1979, 95% of people had indemnity plans. Fast forward 10 years, 1988, 71% of people had indemnity plans. Fast forward another 10 years to 1998, only 14% of people had indemnity plans. And like I said, today it's down to 1%. So this is just a massive, massive shift in how health insurance plans are structured. And before that, you didn't have to worry about a bunch of fucking acronyms. Literally, we're the first generation that has to try and figure out what to make sense of all this stuff. So what was an indemnity plan? It's basically, there's no managed care involved in indemnity plans. It's almost hard to even think about not having managed care anymore because it's so prevalent. And basically all the plans we're going to talk about are managed care plans, all the other ones. So there's no network.
Do you want to just like explain really quick, like what managed care means?
I was going to do it. So all the things I'm about to describe for you are managed care that you don't have to deal with an indemnity plan. Okay.
Okay.
So there's no limited network. You can see any doctor or hospital in the country. That was added as part of the managed care movement in the 1990s. Incredibly. There's no review of your care by your insurance company. So they don't require pre-approvals for anything. And they do not do claims denials. All of that managed care shit added in the 1990s. So it's incredible to think about this, but we've lost all of those things in just the span of 2 or 3 decades. Good job, us, our generation. And maybe the one right before us too. You can sometimes get indemnity plans, but today, even those have been kind of made kind of shit. Usually you can go get the care anywhere you want. You don't have to ask anyone. It won't be reviewed, but they'll make you pay like 20% of the care you get anywhere. So even the modern indemnity plans are not that great anymore. So anyway, it was mostly there for my historical rant though, but I think it's worth acknowledging that all of this crazy shit we're about to talk to you that you have to now figure out and balance and juggle and do trade-offs and stuff is all new to within the last, since the 1990s, basically. Yeah.
So when people tell you like, oh, this is just the way things are, you can be like, absolutely not, because it's not the way things used to be. Exactly. So yeah. So, okay. In modern times, right? We're fast forwarding 20 years here, right? So in the modern times, you are going to need to decode some kind of acronym in order to understand your healthcare plan. today, we have the HMO, or Health Maintenance Organization. Yeah, maintenance is not really a term I want to associate with my health, actually. Like, I'd like to do better than just maintaining, but whatever. Okay. So HMOs, which is, I think a term that a lot of people have heard, right? They actually only represent about 12% of insurance plans. So after they took over in the 90s, old school HMOs are sort of going the way of the dinosaurs. I mean, the way of the indemnity plan. So
just as you start to understand something, it disappears from the insurance landscape. It really sucks.
Not an accident, I would argue.
Yeah.
HMOs usually limit coverage, right? So they limit their coverage to doctors and providers who work with and contract with the HMO. That's where we get the idea of in-network providers, right? It's generally not going to cover out-of-network care, except in an emergency. And they'll decide for you what an emergency means.
Great.
HMOs can also be limited by location, meaning that you might have to live or work in a certain area to be eligible. So if you have an HMO plan in California, you might not be able to see a provider in Massachusetts, et cetera. So.
Right. Now, the next category is very similar. And this is where we really start going down the acronym soup rabbit hole. If you see EPOs, which in the example of my wife's 3 plans that she could choose from, 2 of them were EPOs. One was a PPO. This is an exclusive provider organization. Now, I would encourage you to think of EPOs as almost identical to HMOs. In fact, in that survey saying 12% of insurance plans are HMOs today, they included EPOs under that category.
So we think this is basically like new branding on an old concept.
I think everything is new branding on old concepts. The whole fucking mess of things we're going to talk about. I'm sure 5 years from now, we're going to have like 3 new acronyms and the same old shit. So, but the EPOs, very similar in that they have limited networks. You can't go outside the networks under any circumstances, really. The only difference is that EPOs often have kind of a slightly broader network of hospitals and physicians that you can see. And that unlike HMOs, they don't require a referral to see a specialist as long as you're within that limited network. So again, stay inside the network, but you can just go straight to a specialist if you want to. So very slight difference, but you can see like my wife's employer didn't want to offer anything that was called an HMO. So they instead have EPOs, which sounds better, but there's not that big of a difference.
It has exclusive in the name.
Exactly.
Yeah. So, all right. So we've got our HMOs and our EPOs that are sort of similar. And now we have the PPO, Preferred Provider Organization. Now, so this is actually the absolutely dominant type of health plan in the US today. So like 49% of workers are covered by PPO plans. They're like HMOs and EPOs in that they have a network of providers. However, unlike those other 2 guys, the PPOs will still cover some out-of-network providers. However, the cost of using out-of-network providers is higher. So basically, the plan wants to incentivize you using their own providers. And so they will take on more of the cost if you use their network, right? But you can still see specialists and out-of-network doctors without a referral. Right. PPO. It's a thing. Yeah. You probably have it.
And it's a very subtle difference between having an out-of-network, being able to go to out-of-networks, but paying a shit ton of money for it, and not being able to go out of network at all. To many of us, it might be functionally the same, but there could be circumstances under which you desperately need to see one particular provider. And then in a PPO, you could do that. Just you're paying through the nose for it. So the last type of plan we're going to cover, again, this is kind of an uncommon one, is called a point of service plan.
Or POS.
Right.
I have to interject here and just say that my father worked in health insurance in the 90s when the POS plans were starting. And he let us know the spicy anecdote that around the office at his health insurance company, POS was referred to as piece of shit plans.
Yes. That's probably because he was used to indemnity plans, which no one has anymore. And you'll also notice that the older plans have much worse like marketing verbiage, like preferred provider organization. Sounds like, even though you can't see most providers, that they are just the preferred exclusive group. Exclusive provider. Yeah. So the newer ones, they've worked on their marketing shtick. But anyway, point of service plans, again, very uncommon one. You might never be offered a point of service plan as an option. Only 9% of workers have them. Really, the only difference with this one from all the other ones we've been talking about is that usually they offer national coverage if you're someone who travels a lot. But again, if you go to an out-of-network provider anywhere in the country, big surprise coming here, you will be absolutely screwed with how much money you have to pay with the out-of-network care. So that's it. We hit all the big types of plans out there.
Yes, a lot. All right, so let's just review them very quickly, right? First, we've got the indemnity, which is the one that you don't have to worry about because it was good, so it got phased out. Then we have HMOs and EPOs, right, which are very limited networks. You can't get to care outside the network because that because of that, your premiums might be lower, right? So basically, the insurer screw you there by limiting your network. And then PPOs, right? The most common kind of insurance plan in the country. They're in-network doctors and hospitals where you can get care for lower costs. You can go to out-of-network providers, but it's going to cost you a shit ton of money, and insurers there are basically screwing you by creating major cost barriers for out-of-network care. And then we have the point of service, which we just talked about.
Exactly. All right. Wellness check, sanity check. Has everyone slit their wrists, thrown themselves out the window? We just talked about a bunch of acronyms there, but hopefully we clarified.
Sorry for that noise. You're just going to have to bear with me as I take an antacid.
Taking your fair enough.
Yeah. No, this stuff gives me agita, Ben.
It's not enjoyable, but hopefully this helps a little bit.
Okay.
And again, most of the difference about all that has to do with the networks and who you can see and who you can't see and how much it costs you to do that. So, So that's what the acronyms mean when you hit those acronyms.
Okay. All right. So we went through a lot of acronyms, and now we are going to talk a little bit about some more layers of confusion because it would be almost too easy if all you had to do was understand what you were buying. All right. So, when you go to the exchange, right? So when a lot of people will get their health insurance through the exchange, right? Which is that Healthcare.gov website or whatever your state version is, right? And the plans there are going to be categorized into metal tiers. There is absolutely nothing metal about this. So like heavy metal, like, okay. And these tiers are based on the cost and quality of coverage. It ranges from bronze, which is the shittiest plan, to platinum, which is the rich people plan. Right, Ben?
Oh, yeah. And again, this is if you don't get insurance through your workplace and you have to buy it on your own, you're probably these days buying it through an exchange or through Healthcare.gov, which does the same thing. We don't need to spend a lot of time here because they have very helpfully explain to you the difference between a shitty plan and a really nice plan by using different qualities of metals. What's the bronze anniversary, Jillian? Is that like 2 weeks into your relationship when you don't even know each other? You've slept together twice.
Yeah.
So very simple. A bronze plan, it's going to cost you less upfront to buy it on a monthly basis, but you're going to have the absolute shittiest coverage. All the way up to gold and platinum, it's going to be the opposite. It's going to cost much, much more on a per monthly basis. And we'll again we'll get into these terminology and the definition of premiums and deductibles and all this stuff. But at the platinum level, although you're paying more on a monthly basis, it costs much less to access care when you need it. And you're going to have better access to care. But let me tell you something, as one of the very, very privileged people who has a platinum plan, Those plans also kind of suck. We even the platinum, basically all the plans on the exchanges have limited networks. Every single damn one of them. The platinum plans have super limited networks, and they for what should be a low cost sharing, we actually have pretty high costs when I go to a doctor. If I need to end up at the emergency room, it's $500. My prescription drug costs are actually quite high that I have to pay every time I fill a prescription. So everything in the exchange is not that good, I have to say, compared often to what can sometimes be offered by employers. So.
And the quality, the way that they identify the quality of the tier, right, doesn't necessarily, determine what could be right for you even, right? Like, because like I have a gold plan because there was not a platinum plan available in my part of Texas. But I have a gold plan, but it has a $0 prescription copay. So maybe that's actually better for me than the plan that Ben has or whatever. But
yeah. And I shouldn't say you can buy a good plan, like you can buy fancy plans on the exchange if you're willing to pay higher premiums. They created all these tiers to try and make it easier for like people to be consumers of health insurance, which, as we're talking about, that's the whole purpose of this thing. It's like impossible to be a consumer of health insurance to actually understand what any of this shit means. So they're like, well, if we just make all the insurance companies have to offer the same plan at the silver level, then you can easily choose amongst them which one is cheaper and which one is more expensive. But they didn't include stuff like limited networks. So limited networks were actually kind of created by insurance companies to be able to offer lower premiums on the exchanges. So limited networks are just running rampant in the exchanges. And some of them are extreme limited networks where it's like you almost can't find a provider for some categories of care anywhere near you. So.
And for those folks who are regular listeners, you should totally go back if you haven't heard it and check out our Network So Small episode, which is all about limited networks and how they actually originated in anti-immigrant discrimination in Massachusetts.
We are just trailblazers in many different areas of social justice.
Yeah. All right. So now that you've identified, we got this like kind of overhead view of what kind of a plan that you're getting, right? At that point, it's time for you to look out for the small print, right? And that is going to be difficult to find. So what you need to look for are the SOBs. And in that case, that is not actually a reference to the CEOs of your insurance company. In insurance lingo, SOB is either a summary of benefits or a schedule of benefits. Summary of benefits is the short version. Schedule of benefits is the long version. But basically what both of them do is they give you the deets about what is and what is not covered by your plan. So when you want to look at your plan, you want to analyze that SOB.
I love analyzing the SOBs. That's kind of a living we have here, actually. So we're gonna go through kind of the basic terminology that you're gonna find in the different plans you look at. And the very first term you need to know, obviously, is premiums. The premium, that is the monthly amount that you pay for a plan. Generally, the shittier the plan, the lower the premium. And the nicer the plan, the higher the premium it's going to cost on a monthly basis. But remember the theme of this podcast episode, which is that they're going to get you either way. So they have designed these plans using very, very smart actuaries and economists so that on average, if you pay less upfront, you're going to have to pay about the same amount in the future when you access care. Or when you fill that prescription or when you go to the hospital. So they do try to get you coming and going. And what usually happens is that people who have low income end up buying the low premium plans because that's literally all they can afford. I think that over 70% of people who buy plans on the exchanges are buying the bronze plans, which are the lowest premium, but also the absolute worst coverage, just because you're forced to buy health insurance in some cases, and it's all you can afford on your income. So
yeah, absolutely. Like if you don't have the money for the big plan, then, and you know that you need health insurance, you're definitely going to pick the one that has the lowest out-of-pocket cost because that's all you can afford.
Right.
And we know that that's actually how a lot of seniors actually get stuck on Medicare Advantage plans because they're advertised as these zero premium plans. And then you don't find out until you get entangled with one of them that they're actually not going to cover jack shit.
Right. Yeah, exactly. And I should say, if you do get health insurance through your workplace, there is a premium, but a lot of it is going to be invisible to you. Your employer will pay some share of it, and then you'll pay some share of it,
Mhm.
and you'll only see your share. And you might think I'm paying $200 a month for your insurance company, your insurance plan, but you are not. Your employer is actually paying a huge chunk of the premium as well. And economists have now established that employers do not pay any of health insurance costs.
Yep.
They pass them all onto you in the form of lower wages. So you actually are paying for both. You're paying for your share of the premium, and you are paying for your employer's share of the premium by way of getting less wages than you otherwise would have.
Yeah. So when you think about, like, how much your employer is giving to that health insurance company, just imagine, without our crazy for-profit healthcare system, your employer could be giving that money to you for stuff.
Right. And often it's as much as your wages. I mean, for low wage workers,
Mhm.
it can be $10 an hour just insurance costs. Or
I don't have health insurance until I've already spent $2,000 on healthcare, right? I might as well have no health insurance at all until I've hit that deductible. So keep that one in mind when you're making your choices.
Yeah, and this is where we should talk about. Sometimes you will see deductible or high deductible in the name of the plan that you're looking for. And that means that the plan is coming with a large deductible and that you'll effectively be uninsured until you pay that much out of pocket. So of those 3 plans that I told you about at the very beginning that my wife had to choose from, one was called the Tufts EPO Value Deductible. Now, remember, one of these words, value, is a nice word, so it doesn't mean anything. The Tufts part is the insurance plan. The EPO, remember, EPOs are very similar to HMOs in that they're a limited network. You cannot go outside of the network even if you want to. And deductible means it's a high deductible plan. Now, of all of those, the 3 options my wife had, this is the one with the lowest premium. So she could have got it with paying just a 75, chipping in about $150 per month, which is itself not cheap, but compared to the Tufts PPO and Cigna plan, which was $458 per month, it's the cheapest of all of them. And that's the reason that the premium is lower, is because obviously you have this big deductible, and your insurance is not even going to cover you for anything until you hit that. I haven't looked up what the deductible on this one is, but it's usually like $2,000 or $5,000 for an individual, and for a family, it can go all the way up to $10,000 or $15,000.
Right.
So,
right.
Which, I mean, who of us has that laying around in their bank account?
No.
No. If you do, you probably don't spend any of your time listening to our podcast or watching.
Yeah, that's true.
Yeah. So if you see that, you want to flag that, and sometimes it will a high deductible plan will come along with what's called a health savings account or a personal savings account, a medical savings account. It's mostly a gimmick. It just means you can take money out of your paycheck, put it into the health savings account, and then use that to pay your deductible plan. And the only difference is that money is then pre-tax. It doesn't get taxed as income, but the tax is not that much. So you're barely saving anything with a health savings account. So
plus that health savings account is kind of going to disappear if you don't use it, right?
Yes, and exactly. So often it'll roll over if you put money into it and don't use it. It disappears at the end of the year, and you've lost income money. And high deductible plans have become very, very common. I don't have the number in front of me, but they're extremely prevalent out there. Even a lot of the plans that don't say deductible in the title will have a high deductible. So that's where you want to pull up the summary of benefits or the schedule of benefits and look at what the deductible is for that plan. That's like must know information for your plan. Because if you have a $2,000 deductible and you don't have $2,000 in the bank, you could hit a medical cost that would bankrupt you, or you just literally couldn't get the care you need.
Right.
And this is why, people with high deductibles often act like they're uninsured, is what we've found. Avoid care to the same extent that folks who have no insurance do. So it can be really dangerous. But again, if you don't have money for a better plan, then it's not an option for you. So
yeah. There's a lot of language in purchasing healthcare around choice, but we as with all discussions about choice, we find that certain people have fewer choices than others, and it's usually determined by income.
Yes, exactly. Yeah. All right. So I'm going to move on to another term that is actually also kind of newish, which is coinsurance. Actually, maybe we should combine this one with talking about copays, Jillian.
Okay.
Because copays is the old one that probably a lot of you have heard of. Coinsurance is a new term. I remember the first time I heard about coinsurance, I had been working at this job for, I don't know, 5 or 6 years. And the first time I saw it was in a student health insurance plan.
And I remember this.
You may not know this, but insurers like to experiment on students with the new terrible shit that they're going to roll out on the rest of the population later. But they hit the students with it first. So the first time I saw it was, I think it was UMass, University of Massachusetts was imposing coinsurance on their graduate employees.
And then Ben and I got involved with that campaign, and that's one of the places where we first bonded.
That's right. I think we had a sit-in. We were on the front page of the Metro magazine.
We were. Yeah,
the magazine that was handed out at the subway station.
Do you remember our slogan? Coinsurance is no insurance.
No, it's still good. It still rings true.
Wait. So let's back up for a second, right? So again, people will have heard of copays. So let's just say what they are first, right? So the copay is the fixed amount for you to pay for a doctor's visit or a specialist visit, right? And it can vary based on the type of provider or service, right? You might have one copay for for your general practitioner, and then one copay for your neurologist or something like that, right?
Right. Exactly.
And they also vary based on whether or not you've met your deductible, right? They usually go down at that point because, again, the idea of the deductible is that once you've met it, the insurance is supposed to kick in and cover things.
But you still have to pay more.
But
it's like we're not done screwing you yet. We have a little more to take from you. But yeah, when you pull up that summary of benefits. Most of the summary of benefits is going to be listing your copayments for each type of care. So it'll be, here's the copayment for a tier 1 drug. Here's the copayment for a tier 2 drug. Here's the copayment for a tier 3 drug. If you don't know what tier your drug is, you're screwed because I can't. It's almost impossible to find out. That's not even going to be in the schedule of benefits.
Yeah.
You're going to have to go down a deep rabbit hole to figure that one out. But then it'll say, what's your copayment if you're hospitalized, if you end up in an emergency room, for urgent care, for primary care, for physical therapy, for all that stuff. So this is probably everyone, even if you are not familiar with the term copayment, you've paid one somewhere, right?
Yeah.
If you've got any medical care at all. But coinsurance is a little bit weirder. Instead of going to the doctor and paying, for example, a $25 copayment, coinsurance means you're paying a percentage of the cost of the total cost of the care you're getting. So let's say you have a coinsurance of 20% to see a primary care doctor. If you go to the primary care doctor, you don't know, you probably have no idea what it's going to cost, to be honest. But when you find out, and shockingly, it's, $1,200 or something, you are then on the hook for 20% of that total cost. And then your insurance company will pay the other 80%. Now, if you are in a PPO, which again is the most common type of insurance plan, you're going to very likely see coinsurance in your plan design. Because what they'll do is they'll say, if you see an in-network doctor who we like and we can wring low prices out of, then you'll pay a copayment. Maybe it's $20, $25. But if you go out of network, suddenly you're paying coinsurance. You're paying 20%, 30% of the total costs, which is always going to be way, way, way more expensive than a copayment.
Yeah, that's some serious bullshit. And I think if I were to put it very succinctly, I would say coinsurance is no insurance.
No insurance, exactly. I mean, if you end up hospitalized, it's going to be thousands and thousands of dollars, and you can imagine 20-30% of that is a ton of money.
Yeah.
So, and that's maybe after you've paid a deductible. So any plan that has extensive coinsurance is a bad plan. And again, they use this for out-of-network care to make you look like you can go out of network, but really it's very, very expensive to do that. So
nice. Nice. So now that we know that we have coinsurance, right? There has to be a limit to all of this. And so one of the things that they do tell you in your statement of benefits or your schedule of benefits is the coinsurance out-of-pocket max. So that's the maximum amount of coinsurance money that they can charge you on your plan in a given year.
Right.
Very similar to the next one.
Exactly. So usually your plan will have an out-of-pocket max for the whole plan. So that's the maximum amount you can pay in deductibles, co-payments, and coinsurance. Any of those things that are not a premium that you have to pay for your care.
And that's for prescriptions, visits, all the whole bit, right?
Everything.
Whole bowl of wax.
Exactly. Although I think so, traditional Medicare does not have an out-of-pocket maximum, which is one of the things we've actually been fighting for to improve Medicare, is to create an out-of-pocket max for seniors. But most private insurance plans will have an out-of-pocket max for the whole thing. But then they'll have like a separate out-of-pocket max for prescription payments, and then they'll have a separate out-of-pocket max for co-insurance, and it starts getting janky at that point. You can tell they're finding different ways to screw you. Again, the theme of this episode.
Yeah. And then I understand that in the insurance business they call this your annual exposure.
Oh, really? That sounds like being flashed by a
I think it just means that up to a certain amount your ass isn't covered. You're exposed.
Right.
Oh man. So
sometimes they speak the truth when they're trying to spin things, don't they?
So we got all that stuff, right? We're talking about how much we're thinking now more deeply about this healthcare plan, about how much we're going to pay, how much they're going to pay. And a big part of that, I guess, is who's going to be covered by it, right? And that's where we get to the election tier, right?
Right, exactly. And this is probably a more common sense thing that you can figure out on your own. But the coverage tier just says, are you just covering yourself as an individual? Are you covering yourself plus a spouse? Are you covering yourself plus a family, which could include any number of children? And all of those different options, of course, are gonna cost more or less depending on the number of people covered.
Right.
So
I just feel like we have to explain what an election tier is, because it's the stupidest way to describe what it is. You know, election tier, what does that even make? There are no clues there, no context clues to tell you what exactly they're asking for. Anyway.
Much more easy language could be used for that decision.
Yes.
Who are you covering?
Who are you covering? Simple questions, folks. Explain it to me like I'm 6.
Right.
So, all right. So another term that you want to be familiar with is plan year, right? Just so you know, plan year is 12 months from the date of effective coverage, the date when your coverage kicks in. And deductibles can either apply to a calendar year or a plan year. So you want to pay attention to that too.
Yes. And this is often you will, deductibles are just the worst fucking thing. So what often happens is, let's say you have a $2,000 deductible. They get much, much worse than that. But you have a series of medical incidents over the course of the year. You hit your deductible. That means you spend $2,000 out of pocket, and suddenly your insurance is kicking in, and you're only being screwed with co-payments and not with your deductible anymore. But then, as soon as you hit the end of your plan year, the deductible resets. So that means if you happen to have another, if your care spills over into the next year, suddenly you have to pay another $2,000 out of pocket, and it feels like you're uninsured again.
Oh my God, fuck my life. Ugh.
Yeah. So this happens all the time, where people are waiting for care to roll over into the next year, or because also you really, really don't want to spend up to your deductible at the very end of the year. So let's say you get a terrible issue in November, and the end of your plan year is December. You don't want to spend $2,000 in November and December hitting your deductible, only to then have your plan year roll over, and you immediately have to spend another $2,000 out of pocket. So a lot of people will wait. They'll say, okay, I'm going to hang in there. I'm not going to get any treatment at all until the end of December. So I only have to pay that deductible once. And then at least I'll be, fully insured for the remaining 11 months of the next year. But it's really dangerous, because people obviously end up their situations get worse. They end up in crises. Some people die, just like trying to put off, not flip into the next deductible plan year. So it's so deadly, even though plan year sounds like an innocuous kind of invention. But
yeah. Most of these things, if you haven't noticed, can be deadly.
Yes, seriously.
And they actually named this one after a deadly animal.
Speaking of
which, right? We have cobra. You might have heard about this. If you basically, it means that if you become ineligible for a health insurance plan that you're dependent on, it would be like some common examples of that would be like if you turn 26 and you have to get off your parents' plan, if you're getting a divorce, or if you're getting outsourced and you're losing your job, right? So the payer on the plan basically can elect to keep you on as a dependent and pay an additional amount, right? So in the case of like losing your job, that might be something that you negotiate as part of your severance, is to cover COBRA, right? To cover your health insurance until you find your next job, right? Or at least for a short period of time until you can get yourself settled in some other way. So that's the COBRA.
Yes. And when you end up in a COBRA situation, like if you lose your job and you want to continue getting the same insurance you had through your old workplace, but you're going to quickly find out that under COBRA, you are paying for the full cost of that health plan.
Yeah.
Your employer is not paying anything anymore. And that's usually the shocking moment where people realize exactly how expensive the health insurance is that they've been getting all along through their workplace, which has all been taken out of your wages.
Yeah.
All right, so let's bring this all together, or pick it all apart, Jillian.
You don't want to list off some more acronyms?
No, my God.
I mean, it's worth stating that this is only the beginning, right? Like, this is like the tip of the iceberg. These are
COBRA is my favorite acronym because they chose a deadly animal that most of us think of as something that could kill us,
right?
As a plan for a what is ostensibly a benefit for people.
That's beautiful. That's really beautiful. Yeah. So like, what are our things? Like, I mean, so we've just given you like we said, the tip of the iceberg, right? Here's the very most basic terminology to understand your plan. You might encounter lots of other stuff if you're looking at that SOB that you don't quite understand.
Yeah. So again, this is all an elaborate scheme to screw us over as patients. Don't forget that. But generally, when you're scrolling down a list of plans to choose from, and in the exchange here, we talked about gold, silver, platinum, bronze. But I'm looking here in Massachusetts at a list of bronze, low silver, silver B, silver A2, silver A, low gold, gold, platinum, AI/AN limited cost sharing, AI/AN zero cost sharing.
Oh,
I don't know what those last two are, to be honest, and I do this for a living. I've never heard but here's some of your rules of thumb, right? The less that your premium is, that monthly cost, the worse the plan is going to be. And all you have to do is to dig in to figure out what the worstness is, right? Because it could be worse in terms of limited networks. That's a very common one. It could be worse in terms of high deductibles, right? Another common one. Or it could be worse in terms of copays and coinsurance. And it could be all three bundled together in a nice little shitty package with a very low premium.
It is a shit sandwich with
yes,
shit as both the bread and the filling.
Exactly. So again, usually the PPO plans are going to be a little bit higher premium, whereas the EPO and the HMO plans are usually going to be lower premium. And the indemnity plans, you can't get them anymore, so it's not even worth talking about. But they would be extraordinarily expensive, though, if they offered today what they used to offer back in the 80s, where you could just go to any provider you wanted that was willing to treat you, and you could get the care that they said that you needed instead of the care your insurance said you needed. But this is important to know because you're going to want to know whether your trade-off is losing a network and accessibility of providers, or if it's having this huge deductible that you might have really struggled to pay. So it's important to look that up in the summary of benefits.
Yeah. You want to be careful about the in-app purchases, like I always use this, like the analogy.
Little gamer analogy.
Yeah, the Candy Crush analogy, right? Like Candy Crush is free to download, but if you want to stay alive in the game, you generally have to make some in-app purchases, bonus lives and the whatnot. So don't see that low premium and think like, oh, this is all free, this is awesome, or whatever, because there will be in-app purchases.
Exactly.
And also, can I just say, this is fucking class warfare, right? Like the idea that the only, sorry, if you're working poor, if you only have $500 a month to spend, or I'm sorry, if you only have $100 a month to spend on your health insurance, you are going to end up in a shittier plan, right? Which means that ultimately you're going to pay a larger percentage of your paycheck in copays, in going out of network, in all of those different things, or you're going to ration your healthcare until you eventually die. This is warfare, class warfare, and it's all being waged under the cover of these shitty acronyms.
Exactly.
Sorry, random.
And if you never want to read these acronym names again, if you never want to hear the phrase coinsurance or deductible or indemnity or HMO, all we have to do is pass Medicare for all in this country, and you will have guaranteed access to all the care that you need. It'll just be like the indemnity plans, except you don't have to fucking buy them. All of this will disappear. And just think, basically every country in the developed world, no one has to think about any of this shit.
Yeah.
We're the only ones, the privileged few. So let's get involved. Let's get this shit passed. And
then you only need to know one acronym, which is Medicare for all, M for A.
Exactly. All right. Well, I want to end by thanking our podcast team, without whom we cannot do any of this. Sophia Simeon was the researcher for this episode. Angelique Davis is our podcast manager. Jerry Katz does our show notes. Christian Brandt is going to be the audio editor for this episode. Thanks so much to all of you folks.
God, we love them. They are great.
Yes, and this podcast is a project of the Healthcare Now Education Fund. If you want to donate to the Education Fund to support this and make us let us keep giving crucial information like this that you all know, like how are we getting screwed by our health insurers, you can donate to the Education Fund by going to healthcare-now.org. Thanks so much, everyone. We'll talk to you soon.
Stay safe and stay